open the floor now to questions. This is your time. Hopefully you can jot down some notes and there's some things that you want to know. Both doctors are willing to listen to what you want to hear about. Right.
Not so much of a question, but you mentioned vegan diet. And our daughter is a vegan chef, and she's been telling us for a number of years to go vegan. She is now pregnant, and when she went for her testing, they couldn't believe how great what kind of shape she was in, everything. So I'm trying to introduce it to kind of a little difficult. But it's not a bad diet. It really isn't. I mean, I eat one of my daughters and she has prepared. My older daughter now, she's leaning towards it. So I just wanted to just say that I can't, from just watching my daughter, she's going to be alive.
Yeah, it's a really hard diet to stick to. And it's hard. There aren't a lot of people who can do it. But if anyone tries the vegan diet and finds that their MSA improves a lot, I'd be interested to know. I just think there might be something to this. There are many, many, many factors which I can't really get into because it would take another hour of the interactions between the diet and food and the nervous system and medications. It just gets, the more and more you look into it, the more complicated it is and the more important it looks. So for example, there is recent information to suggest that the abnormalities in the alpha-synuclein might start in the gut. And they may start in the gut and then damage the proteins, and then those damaged proteins are actually transported through nerve cells into the brain. So one very active theory now is that Parkinson's disease and synucleinopathies start in the gut. So if it starts in the gut, that suggests, well, why in the gut? Well, is it the food we eat? Is it toxins that we ingest? Is it infectious? I don't know, it brings up a lot of very interesting
My
questions.
daughter would say yes, yes.
The question over here.
So just to follow up, if you don't think that going vegan is really an option, just go more vegetarian, eat less meat, or...
Again, I don't really know. This is very anecdotal. I'm reluctant to even say anything about it. But it's just very peculiar in my experience. I've had over too many years of treating patients. People will say something really makes a big difference, often some supplement or some change in their diet. But I can't really see a difference. But in these two patients, it looked like they got 3 or 4 years back. And I just have never seen that before from anything else.
Did they know each other?
No, totally independent.
Totally separate from each
They're in
other?
separate cities, actually.
That's what I wanted to share for you next on all this. My husband, just in January, had aspiration pneumonia modeled with the feeding tube. But before that, moving along pretty good at taking Rytary, and then he had to go back to Cinnamon because of the feeding tube to get it through. And with the feeding tube, you have these cans of nutrition. So we're doing the feeding tube, cans of nutrition over the day, and the medication, and we saw the Cinnamon. He wasn't well. We didn't realize what it was. We knew it was just from the feeding tube, from the pneumonia, he just wasn't well. And then our neurologist said, to take the protein, we realized about the protein, that the feeding tube cans, there's like 15 grams of protein per can. So you're having 30 grams of protein at a time. So you're blocking the medicine from working because, as we were told by the neurologist, the cinnamon is blocked by the protein. So we went to the feeding pump at night. So he has 6 cans and all the protein at night. He has the cinnamon 6 times during the day, and it's like night and day. I mean, not about 3 years back, but for him, it was a huge difference. So not that he went vegan, but that he removed all his protein from the time that he takes his medicine, and separating those two was something that anybody should talk to the doctor about, because it really made a difference. I thought he was just kind of on his quick downward decline from January, and then once we did that within 2 weeks, things really changed, and that was a big plus for us. I want to share that.
It's been known for many, many years that proteins in the diet can interfere with the function of levodopa. by a few ways. One is if you have a high protein meal, the stomach doesn't empty as fast. A second way is that there's transport from the intestine into the bloodstream, and the amino acids from food can compete with levodopa for that. And then there's a third way, there's a transport system from the blood into the brain across what's called the blood-brain barrier. And so amino acids from food can compete with levodopa in that place. So there's at least 3 areas. And so in people with Parkinson's disease who have what we call motor fluctuations, on and off spells, we've known for years if you kind of modify their protein intake, usually that means little or no protein for breakfast or lunch and giving more protein for supper, you can overcome the competition and improve response. Now the vegan diet could just be doing that, it's possible. But it seems, in at least these 2 people, was more of a dramatic effect than I've ever seen from a protein redistribution in people with Parkinson's.
I've been on sediment for at least 5 years, and at the beginning I wasn't taking good food. I was getting so nauseous, and my neurologist suggested to try it with food, and I noticed that I was getting the same benefit from it, and I wasn't feeling nauseous. So for years I took sediment with food with no problem. And then last year I switched to Rotary. I don't know if you have any patients who use Rotary, but it was great because it got rid of the off times basically, and that was the feeding tube. They haven't figured out a way to take the Rotary to the feeding tube.
Oh, you just open the capsule?
No, it doesn't.
No, you can't.
No, it gathers. If you get into the stomach, then it hits you all at once. Because the timer it just didn't work right. And to open the capsule, you had to use applesauce and push it with the syringe, and the nurse wouldn't even do it without a written letter from the doctor. The whole thing.
You should be able to do it.
Yeah, in theory, but even you call Terry, call the drug company directly, and they tell you not to do it. So we got it in, but it didn't work as well.
So it's just the cinnamon, it is working, but just like before, the off times are really bad. And this is we can figure out a way to get them feeding to these things. But all of a sudden I realized the problem with the protein that I never had before. So once we figured that out, it's a little better.
Right, yeah, nothing is ever simple. Generally at the beginning you need to give levodopa with food to prevent nausea, but later on, as people are more and more sensitive to the minute-to-minute changes in the level of drug in the blood and the brain, you often have to give it away from protein. There is also a levodopa that's orally disintegrating that dissolves in the stomach. That's another option for some your situation.
Freddie, question?
Yeah, I have more than one.
Okay.
What is the effect of thinning of the RNA over time, ultimately? And is there a long-term, is there an ultimate MSA, people with MSA, correlation with dementia or Lewy bodies?
Lewy bodies are not typically seen in patients with multiple system atrophy, so that I'm starting backwards and working the other way. So you don't see the same pathology that you do in Parkinson's disease in these patients. Dementia can be part of MSA for sure. It's usually not as severe as in other dementia syndromes like Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies. But definitely there are cognitive issues, slowness of thinking, trouble with memory, trouble with planning, trouble with spatial organization, also emotional lability, things like that. But it's not typically as huge a problem as mobility and autonomic dysfunction is. The clinical significance of the thinning of the retinal nerve fiber layer is hard to say. A lot of people with MSA complain of visual problems. Double vision, blurry vision, just feeling like they can't see as clearly. And it's not clear what is causing that. There may be trouble that can be fixed with prisms or changes in the lenses in your glasses. But still frequently you send people to the ophthalmologist. The ophthalmologist says that everything is fine and they still feel like they can't see as well. So I'm not sure that the thinning of that layer in the retina is actually responsible for the problems that we see. We know in Parkinson's disease there are cells that respond to dopamine in the retina too, and that dopamine deficiency in the retina is not improved the way the dopamine deficiency in the brain is improved by giving medicines like levodopa. So it doesn't help people who complain of poor vision. So I think that still remains to be seen, that a lot of those visual complaints are probably due to a lot of different factors, and it's not clear what's ultimately responsible.
And what would cause some days you're feeling dizzy, you're off balance, and other days you're fine as far as the dizziness? You might be the whole day dizzy.
A lot of people say that today's a good day and the whole day is good. Some days are bad days and you did the exact same thing that you did the day before. You had the same amount of sleep, you ate the same food. It's just, I think, it's human nature that some days you have good days, some days you have bad days. And it's part of what is so frustrating about this condition is that it's unpredictable like that you can do everything the same and every day doesn't come out the same. So that's why, especially when we're adjusting medications and looking at the effects of our therapy, that we look at people over a stretch of time. It's not just here, take this pill today and tell me how you feel tomorrow. It's more, take this pill for a month and tell me how you feel at the end of the month. And if the majority of days are better, then we say that it works. And if they're not, then we say that it doesn't.
My husband just switched to prisms in his eyeglasses and said that it made a very big difference in his ability to read and focus.
Yeah. So it's a good idea to see an ophthalmologist. Sometimes when you're at the neurologist's office and they do that follow my finger with your eyes up and down, they can see that your eyes are not exactly moving together, and that's what the prisms can fix, or that they're not lined up exactly right. One might be a little higher, one might be a little lower, and that's where a good ophthalmologist or a neuro-ophthalmologist may be necessary to try and figure out what they need to put in your glasses to line things up. It also becomes hard as we age. We need a different prescription for close and a different prescription for far, and sometimes if your eyes are not moving together, it may be hard to look through the top and then the bottom, so you may actually need separate glasses, so that this is for when I'm reading or when I'm eating, and this one is for when I'm watching the slides that are far away from me, so that adjusting to that sort of bifocal thing doesn't work anymore. And then you have trouble with your depth perception when you're trying to walk, so it affects your balance and it makes you trip if you have something for reading in the bottom of your glasses.
Lloyd?
Yeah, I was wondering if you were aware of a trial for MSA that's going on now at Columbia Medical Institute or Center, and up in New Haven. They're trying to see if there is a particular medication that can be given to people with MSA specific. And I just wondered if you were familiar with it, had any ideas in terms of where it's going, and is it a good idea to participate? I haven't been selected to participate in it yet, but I am trying to see how I can. And so I'm just wondering whether or not it's a good idea or not.
Sure. No, I'm glad you reminded me, actually. To find out what trials are going on related to MSA, go to a website called clinicaltrials.gov. clinicaltrials.gov. And the very first thing it asks you to search for a specific condition, and you can just enter MSA. If you do that, you'll see there's about 3 pages, which means there's about probably 40 active studies going on. It includes many of the studies that have closed enrollment but are still active. But there's probably about 40 studies. Most of them are the studies, like I had mentioned, that they're looking at drugs that interfere with oxidative stress and some of the same medicines that have been tested in Parkinson's disease, Huntington's disease, other degenerative illnesses. Some are not treatment studies, actually. They're looking at biomarkers, or they're looking at radiological changes. But I don't know specifically which one is at Columbia, but you would be able to find out on clinicaltrials.gov. There's also, right in front of you, some of my papers, and on the bottom, I brought a few, the bottom one there. I brought a few copies of a study that's recruiting patients with MSA, and this one's brought by AstraZeneca.
Who was in that study?
And so, but you can find that study again if you go on clinicaltrials.gov. But I don't know exactly what the one is from Columbia.
What's your thoughts on around trials anyway? Do you encourage them or discourage them?
Oh, absolutely. No, I think that's going to be the key to future success, are these clinical trials. There are a lot of good ideas out there and hypotheses, but the only way we'll ever know if they're right is to actually test people with the condition, and that's through well-run, what are called controlled clinical trials, where you'll have a placebo, you'll have someone randomized to either placebo or active drug, and those are the studies that are designed to eliminate biases in terms of assessing the value of certain experimental medications. And absolutely, I mean, that's one of the things Amy and I do a lot is clinical trials, and the work we've done in the patients who have participated in these clinical trials many, many times, because of their involvement, there are new medicines on the market, there are new treatments, there are new things that we know about the conditions which make it more likely we're going to find a cure at some point. So it's probably the most important thing that people with MSA can do to help others.
I have one more question. It's related to exercise. And I have this erratic blood pressure that the least little exertion, raises the blood pressure, and sometimes it decreases the blood pressure, and that has happened as well. And I know you're a doctor and all, but then you can't really diagnose my problem. But I don't know what the substitution for the exercise.
Well,
So,
generally what you want to do is to work with a trainer. So most physical trainers will be able to assess your medical limitations and develop some kind of program that would be safe for you to do. So, for example, you might use exercise equipment in a recumbent position. There's exercise equipment that you can do seated on your couch, where you just do a rotating thing with your hands or your feet, and you're just sitting there in your living room. So there are lots of new and a variety of different pieces of exercise equipment that can be used for people with a whole variety of medical limitations.
And we have an outstanding therapist that's going to be speaking after lunch. She's terrific, very well versed, very experienced, specifically in Parkinson's and related diseases. So I think that you'll find that presentation very helpful, and you'll have the opportunity to ask questions there as well.
That is a special thing for people with MSA because of the orthostatic hypotension.
We've done exercises in the pool, so people who live there.
The pool is good, except you don't want people passing out.
No, right, it's the lifeguard did too, so.
Did you want to add anything?
I just wanted to go back to the research, is that I think that some people have a sort of misconception that the drug that they're studying is already a treatment for the disease, and so that they don't want to be in a study where they could be given a placebo or fake medicine. But the reason that we study these medicines is to find out whether the drugs actually work or whether they don't. Whether they have side effects that are tolerable or whether they don't, and what we need to worry about in the future if the drug is going to market. And there is also something that we call the placebo effect, that just being in a drug study where you're being given a drug that you think might help your disease makes you feel better. And so I encourage people to participate in research because, I mean, yes, in terms of science, I would love to be part of the research study that finds the cure for MSA, but in reality, if being in a research study makes my patient feel better today, then that's really all I care about. I want them to feel better. So I think that if you have any interest in participating in research, it is a great thing to do. It helps us know more about the drugs that we study, the disease that we study, and it's sort of your way of giving back to the community and helping not only yourself but potentially other people with this condition so that we can understand it and have better ways of managing it. So even, I participated in studies with MSA where all we did was examine people every 9 months and write down what we found when we examined them, and we didn't offer them any kind of therapy, but I think we learned a great deal from that kind of a long-term study to be able to use now to help other people with MSA. So all of those things are very, very useful, and I wouldn't shy away from it just because potentially you think you're not going to get real medicine.
Before we go to the next question, I just, as a non-medical person, any little thing that we did with Mom helped us to overcome a little bit of that feeling of helplessness to this disease. It was empowering. You felt like you were at least accomplishing something. And that, I think, ties to what you're talking about as well. There's some benefit to it. Yes, you've been reading.
I have a few related questions. Is it known whether MSA is hereditary? And are there any predisposing factors or any causes?
It doesn't seem to be hereditary. There hasn't been a gene discovered where it's MSA that runs in families. There are definitely other things that can look like MSA. So as we talked about before, it can be confused with Parkinson's disease. And the side effects of Parkinson's medicines can make your blood pressure drop, you get constipation, and so you could think it's that. There's other medicines like, for example, Depakote, which is an anti-seizure medicine or can be used as a mood stabilizer. There have been reports of people who were on Depakote who looked like they had MSA, and then you take them off the Depakote and all those MSA symptoms go away. So that's why when you come to the doctor with symptoms, everybody's looking at all your medicines and hoping that they could blame it on something else that could just be removed and then all the symptoms would get better.
So it's not known if there's a cause or anything that someone does to...
There's nothing. No, you didn't do, nobody did anything to get themselves this. It's not like, but,
Yeah.
like people that get like, okay, I'm gonna use Muhammad Ali as an example, like he has Parkinson's now, and it's because he was a boxer, and you get so many blows to your head, then you can end up with potentially dementia, or you can end up with Parkinsonism. And so, yes, so that behavior caused the problem. But MSA, there's nothing like that.
And then I just have a very small, literally, other thing that's not related to that, which is with all the symptoms discussed, I didn't see micrographia, and my mom's first symptom was the teeny tiny illegible handwriting.
So that goes along with the Parkinsonism. So slowness of movement, stiffness of muscles, tremor, soft voice, sort of a blank facial expression. You can see tiny handwriting. You can have trouble cutting your food, trouble with small motor movements like buttoning buttons, tying shoes, putting on your jewelry, trouble with short steps, decreased arm swing, everything that we see in Parkinson's.
So can someone be classified as, because I was so interested to see the two types, the C or the B. We were thinking my mom might be the C type, but can someone have elements of both?
Yes, absolutely. Because usually one is more obvious than the other. But you can have some ataxia with the Parkinson's variant, and you definitely can have some Parkinsonism with the cerebellum variant.
Thank you very much.
Ready?
Yeah, okay, that was the question I wanted to ask you. And people have both the P and the C, but I just want to mention about trials. Katie and I have done over 12 trials in the last 2 years, and we've done over 12 trials in the last 2 years, and I was very active with the Michael J. Fox for a while until we found out it wasn't Parkinson's, but it was MSA. But one thing I learned, which was troubling, that 60% of trials failed because of the lack of volunteers. And therefore, there's no cure. So whatever you can do to get other people to volunteer would help the cause.
It's a great point. Thank you.
And just to piggyback on this lady's observation, it took almost 2 years before I was diagnosed with MSA. I mean, they couldn't figure it out. I mean, I went to nephrologist, neurologist. I went to so many doctors, and they was thinking that it was something that they didn't know, and they didn't know, obviously. And it took
2 years is short.
yeah.
It took us 5 years.
So, and that's, again, one of the reasons that I mentioned that a movement disorder's neurologist is generally your best bet. Most people we see probably have seen, on average, maybe 3 to 5 other doctors or neurologists before they get proper diagnosis. That's the norm. You did pretty well.
We went to Columbia University in New York, the neurology department, saw 4 doctors that didn't diagnose.
Yeah, Dr. Colcher mentioned it's not an easy diagnosis, especially at the beginning.
A gentleman in Florida, Dr. Hammond, specialized in movement disorders. We took her into the hospital for pneumonia, and because she was so out of balance and everything, when she went in, they sent him in as a neurologist to look at her. Stood there looking at her, making her move and everything. Said, don't think she has Parkinson's, but she may have MSA. And that was the first time in 5 years going to different doctors, neurologists, and everybody, that anybody ever said MSA to us. And then it turns out that
My guess is you're going to hear the same story from everybody.
it wasn't explained to us. This is the hard part about it. It was not explained to us. Someone, a therapist at the hospital, saw it on my wife's chart and brought her information for a support group. And all this information was horrible to read. It was very disheartening. And as it turns out, I finally took her to Cleveland Clinic in Western Florida for a neurologist who had MSA under her heading, and she did that study on her. And and that's how we finally got the diagnosis.
But remember, a DAT scan won't distinguish MSA from Parkinson's disease.
Right, but she had everything else going for her, you know, that was right along with the DAT scan. It's just right there.
As I suspected, the question and answers is very beneficial. I want to watch the time. I've got 4 hands up still that I want to make sure I get to those 4, and I think that's going to kind of wind us up in this section. So I'm going to go to the back. I'm sorry, I don't know your name. You had your hand up earlier.
I was just going to say, you know, I've learned neurology is a very gray area and difficult for doctors to diagnose. But a lot of the timing, too, is like in any specialty. You can't just, you know, my husband goes to Jeff. You can't just call them up and say, I want to see this specialist. You have to go to a regular neurologist who then refers you to the next step. You know what I mean? So that's, I know that was part of our frustration. My husband's a physician, but, you know, it doesn't mean you can, you know, cut the line. Until you present with very, very specific symptoms, they're not going to let you see the proper specialist.
I'd say that's not true in many instances.
No, okay.
That's pretty unusual.
He was, okay, sent away even. He was sent away from Penn. Yeah.
The gentleman behind you, again, I don't know the name yet.
Yeah, just 2 quick questions. One, have there been any herbal supplements that have helped? We tried some medical marijuana by a pill to help sleep, and it had a significant impact for sleeping. I don't know how you familiar with that. Is there any possibilities there? And then clinical studies that we try to get into, we've mostly been told no, because MSA doesn't fit a lot of different types of symptoms, and when it's an MSA-specific study, we so far have been limited to the amount of people that let in. So any advice on how to get ahead of that, either front of the line or at the back of the line, deal.
In terms of nutritional supplements, all sorts of things have been brought up. They're the same thing with Parkinson's disease. They're generally in the area of antioxidants. But a variety of studies that have actually formally looked at these antioxidants have not been able to find any benefit. In terms of medical marijuana, there's very few studies done with medical marijuana in almost anything. This is not the country to do studies of medical marijuana. It's a very conservative environment that's difficult to do it. Most of the studies that have been done with medical marijuana, Parkinson's disease and other movement disorders come from either Holland or Israel. And they've generally been very mixed. Some have reported some benefit in Parkinson's conditions, others have found no benefit. So it's really not known. It's not a condition in New Jersey, at least, where that is approved for distribution of medical marijuana. But the effect is going to be the same as if you didn't have MSA, so people may feel relaxed or they may be hungry. But so you're going to get those things whether you have MSA or not. The question always is it something specific about the illness that it's changing? There hasn't
We've been
been
frustrated with the sleeping aspect, that the sleeping component of it. We haven't been able to find a drug that works consistently. And a few times we've tried it, that works pretty well. I wonder if that has any wherewithal about that at all. That's the one area that has.
Again, going back to, there are a lot of sleep disorders associated with multiple system atrophy, so sometimes going to a sleep specialist, getting a sleep study and finding out exactly what is the problem that you're treating, just like Dr. Kurlan said with the urologic symptoms, that you can throw sleeping pills at somebody, but if they're not treating the right issue, then it's not going to make their sleep any better. So that's probably the way to go if you're finding that the trial and error method is not working so well.
The most common disorder associated with MSA would likely be REM sleep behavior disorder. And so the most commonly used medication for that is Klonopin.
That was
Sorry, Marcia?
No, thank you.
Okay. The brain stimulation surgery
Louder.
is thought to be successful.
No,
BBS.
not for
Not for
MSA.
MSA.
It really, unfortunately, when I was at Penn, we published the patients that we did that should not have been done. It actually makes it worse.
So you want to save deep brain stimulation for people with Parkinson's disease, essential tremor, or dystonia, and not operate on people with multiple system atrophy because they don't do well.
At least with the targets that we know
That we
of.
have now.
So also keep in mind that for most centers that do DBS, the diagnosis of MSA would be an exclusion automatically. So there's not a lot of experience. So early on, there were more people tested because nobody knew. And so pretty much everything was tried, all different Parkinsonian disorders. And most experience has been that for MSA, it's not a good approach. But the data is, there's not a lot of it because most patients are just automatically excluded.
Patricia?
I wanted to ask about, I've had 2 patients with MSA, and both patients were misdiagnosed for many, 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 many years.
And Patricia, by the way, is a hospice nurse.
And the doctors, I mean, first it was Parkinson's, then it was, back in the day, Shy-Drager syndrome. And they found that unless they went, both families, out of state to a huge university hospital, they were not able to be diagnosed. And the doctors that they saw here, locally, didn't send them to movement neurologists, they asked what other kind of neurologist should I go to. What is the availability of seeing movement neurologists in local hospitals, and are those doctors only in the big university hospitals? I think it's very frustrating when I hear these stories, and I think, wow, 8 years and you've been treated for Parkinson's disease with really no improvement whatsoever and a constant decline, and nobody picked it up. I guess I'm asking you, how do they go? How do they ask their doctors, where can I go for something more? Some people are elderly and they're not as able to go, assertive, doctors of God, and they're not going to ask questions of the doctor that they've been seeing for 5 years. But also they're not on a computer, and they're not knowing how to research, and they're not knowing how to do those things. Is there an answer to that?
I think I encourage my patients always, if they have any questions about their diagnosis or about the management of their disease, to seek another opinion. Movement disorders I'm trying to think how long there have been movement disorder fellowships. It hasn't been that long that there were as many programs as there are right now.
1980s.
But I don't know that a lot of people go, once they do a fellowship where they're trained to do research, that I don't know how many of those people actually just go into private practice and don't work at some academic center. I think it's frequent that we stay where we can continue to do clinical trials and practice ourselves. But I think that sort of is a mindset for that sort of everybody should have that attitude, that whether it's a family practice, whether they're family physician or somebody else, that if they don't feel that they're getting the answers that they need, that they go somewhere else. And it should not be so hard when you find somebody who has expertise in Parkinson's disease, that they would be able to make that differentiation between Parkinson's and MSA, especially if it's been a number of years and they're doing worse on their medicine rather than better. That is very typical of other Parkinson's syndromes and should raise a red flag to the doctor that this is not regular Parkinson's disease.
An education for nurses.
Yeah.
I would love to see patients before they get so sick that they may need services that we have, or have declined before they need the services that I do. To train nurses to know about this disease, to do the very best with their patients, are there trainings for that?
Well, the problem is it's not a very common condition.
But I will
So-
say that the MSA Coalition
Right.
has really started, and has been now, doing CME. It's right now geared toward physicians, but it's a step in the right direction. So that is happening.
Just to point out, there's, I think, about 8 movement disorders neurologists in the state of
13, actually. I work for the American Parkinson's Disease Association. I'm the information referral coordinator for the state. We have about 13 movement disorder specialists in the state currently. And for your question about the locations, they are based in the university hospitals. We try to give as many talks as possible, conferences. We actually have a conference coming up. We have CEUs that we're trying to do for healthcare providers. Thank you. So,
But that's
for nurses as well.
the purpose and advantage of meetings like this, of a support group. And people, the first thing when somebody walks into the support group, they're going to hear from their peers, have you seen a movement disorder specialist? So you learn things from everyone else. It's a community. You go online, in blogs, chat rooms, that's what you hear. Most people with MSA are referred to a movement disorder specialist with a diagnosis of Parkinson's disease. And that's generally how you get into a movement disorder specialist. If you have a diagnosis of Parkinson's disease or Parkinsonism, you're going to see a movement disorder specialist in most university settings that have a movement disorder specialist. That's usually the entree. They're referred because there's something funny about them. They don't seem exactly like Parkinson's disease. And that's how the referral usually happens.
We got
Do you think that there's a hesitancy among neurologists to use the term MSA? Because I don't know if you remember when we first met with you, we had seen some pretty, what we thought were big names in movement disorder, and no one had ever said MSA to us. They said atypical Parkinsonian syndrome, and so I wondered if there's some hesitancy that,
I don't think so.
it was odd to us.
But just like any other field or any other physician, there are some good movement disorder specialists and there are some not so good. So you have to kind of be careful.
and there are some good ones that may miss it, as you both have pointed out, because it's such a difficult disease and it presents so differently.
Do you use other diseases?
But we called it Parkinson's plus. Shy-Drager syndrome, multiple system atrophy, olivopontocerebellar atrophy, like all of these things are names for the same thing. The striatonegral degeneration, they're all grouped into multiple system atrophy now. But it seemed like they were all different diseases until we had some more understanding of what goes wrong in the brain, that we could group them all into one group. So the terminology may be different from person to person that you see, but hopefully their description of what that means and what's coming in the future or what to be wary of is still there, no matter what you call it.
Okay, we're going to take our last couple of questions here. Lloyd, and then Tom will come to you, and then these last 3. That's it. We're going to have to
Well, I'm taking off my patient hat
Okay.
and putting on my apathy hat
Okay, go for
because
it.
I think it's important. I've been to maybe 2 Parkinson's support groups, and I've been to 1. I've been diagnosed about 3 months ago, and I find this kind of support group activity the best medication that I could take, and because of that, I want to put the 2 doctors on notice or point. Yeah, you probably weren't ready for this, but I'm going to say it anyway. Cindy has been looking for a home for a long time, and I don't live anywhere close to Mobile Hospital, and I think it'd be fantastic if we can spurn and spin off a number of support groups for MSA specific, you know, in sort of these hospitals. And I guess the lady back there said university hospitals are more prone to do that. But long story short is, I'm going to ask you a question of how and what do you think are some of the best approaches to these hospitals to get support groups inside of them, and supporting them, so that we'll have more MSA support groups. Because support groups are very important. They're very important. I'm just surprised at the number of people out here that have my problem, and I'll learn probably more from them just having the opportunity to sit and talk with them than anything else. And so I'm asking you, as presenters and as doctors, how can we, or how can Cynthia, do what is necessary? And if we, as patients, can be supporters, then we want to know what our role can be in that regard.
And before I let the doctors answer, just to give you a moment of history, you're singing to the choir a little bit, because we're at Overlook and we tried at Cooper. Dr. Colcher was instrumental in connecting us and get us started. One of the issues, and I think it's sort of speaking to what you're asking about, is there wasn't sufficient attendance. How do we get the word out to your patients? How do we encourage them to come? How do we make them understand the importance and the significance, and have experience that benefit, and also help the others that are seeking it?
And make additional connections beyond this particular network we're in right now, to expand into Monmouth, Ocean County, Bourbon County.
Yes. So.
Well,
So
I
the
think
next segue.
the first step is to identify a physician who takes care of MSA patients. So if that type of practice doesn't exist in a center, they're probably not going to be too interested. So you need an advocate from the inside. So Cindy came to us as we have, I think, one of the biggest movement disorders practices in the state. Asked if we could help find space.
And that actually came from one of our patients.
If the doctor fires up at your office one day and they was Diane, we're chasing down the hall to try to talk to her.
Yeah, I mean, it's something that's done all the time. I mean, in our department, we have support groups for Parkinson's disease, MSA. We have Tourette syndrome. We have head injury, Alzheimer's disease, stroke. So that's what neurology departments do. But it's going to happen for MSA when there's a special interest in movement disorders.
Also, if you contact...
Is there some specific things we could do to motivate the hospital to have these support groups?
Most hospitals are happy to do it.
I think that they're willing. I think even in my experience, and you can ask Joellen when she's here for the physical therapist. We had an MSA support group when I was at Pennsylvania Hospital as well. It's the transportation and the attendance. It's not so much that the centers are not willing to host it. It's that it's challenging for people to get there. It's just, if you do it on a Saturday morning or you do it at a certain time, it's logistically hard. So that makes it a little bit more of a challenge.
Also, keep in mind that not everyone with a particular illness wants to go to a support group. So this happens over and over again. Many people don't want to talk about their illness with others. Many people are socially, they don't want to appear in public as a disabled person. Many people who have early just diagnosed MSA don't want to see people with advanced MSA. This illness itself and other Parkinsonian disorders has frontal lobe involvement that often causes what we call apathy who are trouble with motivation. And so it's hard to get people to do something. Their spouses, you say, it's the bump on the log syndrome. It's hard to get them off their butt and do something. And so there are a lot of reasons that you can have the world's greatest support group and you can offer lots of help and services, but a lot of people, a high percentage of people just don't want to do it. Now, many, many, many times they go to their first meeting and they come out from that on because a lot of their fears were unfounded. But to get somebody to that first meeting is often really, really hard.
I'm going to move this along, Tom, and then Ruth, and then we're going to break for lunch.
I have a question, but just to follow up on that. Both the supporters in New York City and in New Jersey, quite frequently people come for one meeting and then never come back. I think for the most part, I'm looking for a cure, I'm looking for some kind of answer, and they grant or something like that. But I've gone to NYU to pursue clinical trials to Dr. Kaufman. I'm glad to see his wife who works in the office too. Something later. But they talked to me about fluoxetine, apparently in Europe. There were adult studies involving fluoxetine that very helpful that they had progressed to a human study. But this is a known drug, it's Prozac actually. And that's not for depression, but it's that there's been a number of patients since it's low risk. I tried it for a while, and I thought it was helping me by swallowing and speech. But when I went to the doctors there, they said that they've seen another case of that you've seen. And they say, it's not supposed to see nothing further this at all.
I only stopped taking it because we were upping the dose, and at the higher dose, Tom got dizzy, and then there was sort of falling, so we completely came off. But he was looking to go back on it at a low dose to see if it does help with the speech and swallowing. He has a feed tube when you get pleasure feed puree things. Do you have any experience with fluoxetine?
Well, the rationale for fluoxetine is the one I mentioned. There's evidence in animal models and also epidemiologically that antidepressants, almost every one of them, seems to interfere with the aggregation of alpha-synuclein. So that's a direction that people are looking for all Parkinson's, all the synucleinopathies. There's nothing specifically different about fluoxetine than the other ones that I know of.
Would it take the swallowing directly, or you don't?
Again, the approach is not to help the symptoms. The approach is what's called neuroprotective, to try to keep the brain cells healthier, slow the progression of the illness by preventing the buildup of the alpha-synuclein. And as I concluded what I said about research, I think that's going to be the focus of MSA in most of these synucleinopathies for quite a while.
And he felt an improvement. Is that possible, or is it just be? I don't know. It's not. You haven't seen that like that. Fluoxetine caused an improvement in swallowing across the board yet.
But yeah, I haven't really
it could
looked
have,
at
but right.
That's not the purpose people are looking at.
Right.
And our last question, Ruth.
Yes, we have a question about safety during a low blood pressure episode. We're concerned that when this happens, sometimes the patient is almost semi-conscious, can't speak, can't move, and
Sometimes they're unconscious.
right. And in an assisted living situation, what kind of instructions should we be giving to caregivers so that we're sure that she's safe and that we just don't, we know what to do when we're there, but when we're not there, we want to give them the proper instructions. Their position is sometimes to leave the patient until she comes out of it. Well, I don't think that that's necessarily a safe situation.
Ideally, what you want to do is you're doing everything to restore blood flow to the brain. So if somebody is feeling lightheaded or dizzy or someone is starting to pass out, the safest thing for them is to get them lying flat.
Feet up.
But sometimes
Head down.
So to take them out of the situation they're in and put them flat.
Flat, feet up, head down. And the next step, if you had to, would be to infuse intravenous fluids, but generally a nursing home's not going to be able to do.
Right. But just having them lie down is probably sufficient.
Same thing as if anyone has.
Dr. Kurlan, Dr. Colcher, thank you very much.